Good afternoon, everyone. My name is Kristen Kafka, and I work at IQVIA, which you probably don't know as a company because hardly anyone knows it is IMS Health and Quintiles. And you probably have seen some thoughtware from my colleagues at Linguamatics. And in just a moment, I think the screen will come up. So I'm going to talk to you about the future. And bear with me, because I know we're in the present, and sometimes it's a little bumpy to think about the future. So my role, I spend a lot of time thinking about ways to aggregate data and to streamline and have efficiencies with the data that we're collecting. And I spend an incredible amount of time in the open source community. And I use this word that you might have heard a few times throughout the conference, OMOP. OMOP is a common data model. It is part of the Odyssey community, which is an observational health and data sciences and informatics community, really trying to bring together people who have an interest in reusing observational data for retrospective purposes, whether it's reporting or for research studies. But we have a challenge today, and that is that we get an incomplete picture of people in our data. We see whatever is codified, and sometimes it's helpful, sometimes there are holes in it, sometimes we don't even know what to do. And we have to find ways to incorporate the unstructured information that is inside of our clinical records. And there's really this world of moving to completeness. Whether you use my favorite NLP solution or your own, there are lots of tools that are available out there that can harvest your unstructured information and put it into something you could use for reporting and you can use for research purposes. Because ultimately, we have the ability now with natural language processing to find sets of keywords that our manual abstractors are equally looking for, to tag them with meaning, and to use that for analytics and outcomes. So I'm going to show you one more slide before we get into the actual demo, which is, if you've never seen it, here's the mystery solved. This is the OMOP Common Data Model. Congratulations, you're now an expert. This is really an eyesore, and we're not going to get into this other than I'm going to be telling you about how this is an available information model. Should you have an interest in aggregating your data into standard tables, there's a whole community with a GitHub out there that could help you in your journey. And I'm going to talk to you about one specific table, the Note NLP table. How could I take unstructured information and standardize it and reuse it across my analytics platform? And when we think about HEDIS reporting, it's really this idea of marrying the hybridness of how we see patients. So can we complete the view of them through an unstructured data feed? Can we map it to a common data model, maybe a common ontology? That's a huge piece of the OMOP Common Data Model. Could we then merge it to create that puzzle that is complete, and then maybe use it for reporting? So that's what we're going to do. We're going to utilize a single measure and look at this thought experiment that we did. So I'm not going to walk you through all of this. Instead, we're going to jump into the measure. We heard a lot about breast cancer and how there's a lot of innovation going on around the genomics side of the house. But if you're not even into collecting genomics data yet, you have the opportunity to take this hybrid measure and to look into your clinical records and to augment what you know. So it's a cohort that we're looking for. We know the age range, we know the procedure we're looking for, we know the time capture period. And so what do we need to do? Well, maybe in our view today, we have a solution that we can go out and say, you know what, my claims data is not doing this for me, I need to pull more. And I want to do this semi-automatedly because unfortunately, I don't have an infinite amount of humans, I need some support. So maybe I run an algorithm and I get this beautiful view that shows me all these different colors. The colors relate to different meanings that the algorithm sees, terms that relate, how the term applies. And I'll get an extract, something that is super usable, an Excel file, right? You guys use Excel files all the time. It's like slightly more usable than a PDF. But in itself, it still needs a human to actually take it and ascribe the meaning, to make that value set, to create that measure. So I could, this is going to be where the fun part comes in, I'm asking the computer to do a couple of things. So I could load that table into an analytics environment. Maybe I like R, maybe I use SQL Server. I don't really care how you munge your data, but you might want to pull that file in, and you might want to ascribe some meaning to it. Maybe you simply dump it into a straight one-to-one match of the data model, and you dump it into this note table. And all that's literally doing is taking that one table and standardizing it into a quick view. But it looks pretty similar. All we see are these big blobs of text that we are pretty sure are related to the measure we're looking for, but I don't really know much else. I can see what language it's coded in and the date time, but that's only so far. I could get fancier and maybe write an ETL script to take that data, look against a standard ontology. So in the OMOP Common Data Model, there are standard vocabularies. These are things that you know, like SNOMED codes, CPT4, LOINC. Insert your favorite source vocabulary. There's a map to a standard. I could actually have it look at those lexical terms and parse it in a way that it ascribes meaning, such that I get to a table that then has the term that I pulled from the record, that thing that I actually really need to create the measure, and the concept that makes it connect across all systems, and I know where I took it from. And as I get more sophisticated, I could ascribe even the exact position of where that was extracted. In the file I received today, I don't know exactly in the screen, so I don't have offsets, but those would be almost like coordinates on a map, exactly where you could find it. So, because we've heard we don't trust our data, we might need that as a breadcrumb to go back and validate we feel comfortable with what we have. And the idea here is that once I get to this step, that's when the fun happens. And I know that you guys are like, this is just tables, like this isn't even that exciting. Oh, it's about to get really exciting. I'm a data nerd, and I am part of a community that has publicly available tools to help people then take the standards you've mapped this to and create clinically meaningful questions. So I have this tool called Athena. It's publicly available. It's an ontology browser. It's freely available, athena.odyssey.org, and I have the ability to search the code that it's ascribed this clinical lexical term to, and I can see it's screening mammography. Okay, that's pretty standard. I've asked it for that. But what's really cool is because I'm mapping to a standard vocabulary, I can then click and play around with what does this mean about other things that are related to this term. So as you might imagine, we code in different levels of specificity. We have ways of being at a certain level, or we have ways of going up and being more generic. By creating your map to the standard vocabulary, you can then play around analytically with whichever level of detail suffices for your report. And you don't have to do this manually. This is a lookup table that is simply searching that value that was ascribed by the software and then helping you create the right view of that value set. And maybe I've already lost you. Maybe this isn't even that cool. But I'm going to take you one step further. Imagine a world where you've gone through this hard part, you've worked with your technical team, you have this stored in a data model. You could then use another publicly available tool called Atlas, which is essentially a toolkit to help you build cohorts and run studies on data marts that you create. And I could create an eligible population, instead of just what's in that PDF, I could apply that logic, I could create a cohort entry event. I could even ascribe things like frailty values and use those concept sets to define what they are. And what's really cool about this is then from there, I have JSON objects that I can then run and turn into calculations. And I could totally just be speaking in tongues to you, but this is imagining a world where no matter how you get to the end game of reporting, you have opportunity here. So today, you might just decide to take the value sets and create a calculation and use your favorite reporting tool to generate an XML file. But longer term, the idea of plugging into something like Atlas is that you actually have a shareable framework where we could test these digital measures together, share reusable objects, and create a library of validated measures that could be run off of that ETL backend. So that's the future, and maybe it feels kind of scary, but ultimately we're just talking about the anatomy of the quality measure. We have a model that can help us standardize how we see time starting and ending. When do you enter the data set? So that in claims is an enrollment file. In EHR, it's when do you start interacting with your provider? How long does the provider see you? We can ascribe when the measurement year starts, maybe add an inclusion event, an exclusion event, and even when the year ends. And ultimately, we have these wonderful Lego blocks of ways to ascribe and create these measures in such a way that you can have it be reusable and repeatable, and you can adjust it over time. So that's the vision. I know many of you are still in the here and now. I'm still here and now too, but the idea is that we have a lot that we have available in this unstructured information. We could harvest it and augment what we see, and we can have a discussion as a community around the validation and the quality assurance for that. But there's a potential here to help make sure that we're really doing good on the patient, that if their provider has encoded this, even in free text, we can use it, and we can use it in a way that is meaningful. So that is my pitch. It's pretty quick and fast and furious, but it's the idea of there are lots of opportunities out there, lots of tools, and we have the ability to think through data standardization and integration and normalization so that your reports are not bespoke. Because ultimately, what you really want to do is have a pulse on what you're like all year long. And if you ascribe to the standardization and you utilize these things that help increase the time to get information in, you can really have that ability to monitor yourself throughout the year and be proactive. And I think that's the exciting part, is that you can minimize the burden and you can put some of this on the machine. I know we're afraid robots are taking our jobs, but I'm perfectly fine to delegate parsing text to a robot. I don't know about you guys. So, if you're curious about the thought experiment and you'd like to learn more, we have this thing in the Odyssey community. We say, join the journey. It's like Odysseus. It's very circuitous. We might get lost along the way. But we're trying to find ways to make it easier to be more transparent about the way we calculate things with observational data. And that's my pitch. So I hope you guys get excited about the future. And if not, I heard there's a really exciting pilot after me that might be more interesting. So you never know. There's a lot in the future out there. So thank you for your time.
Good afternoon, everyone. My name is Claude Nanjo. I'm from the University of Utah. I'm a senior clinical informaticist and research associate at the University of Utah. And what I'd like to do today is to present you a little demonstration, a fairly simple demonstration on the coordination of clinical decision support with measures and their integration into a clinical workflow. So while the demo actually appears fairly simple, it's actually very sophisticated in the way it integrates a number of standards together. And it also takes the CQL that you know that are used to author performance measures, and it actually executes them on the fly in a CDS application. So I'll explain that whole process. So when we look at knowledge, we can think of it in multiple levels. So what we call L1 knowledge tends to be narrative. It's unstructured. It's written. It's primarily for human audience, and it's generally not computable unless you actually run natural language processing. The second is semi-structured. So you take this unstructured narrative, and then you start progressively adding some structure. And generally, again, it's good for human consumption. It's generally not machine processable unless the grammar that's used is very strict, but it becomes more and more structured. Then you hit L3. So L3 is structured, and it's computer or machine readable, but it's platform independent. So it means that you're representing it in a way that a machine can understand, but it's not necessarily tied to any specific implementation platform, like, for example, Java or C# and so on. And this is the world we operate on right now. Then there's L4. L4 is executable, so if you actually want to run this in your system, it has to be L4. So if I want to run an application in a Java-based environment and I need to translate my my platform-independent model into something that can run on a platform-specific implementation or technology running in my system. So here, I just put this slide up just to give the context. So when we think about quality, we have to think in terms of a continuous process. We develop what we think are best practices. We review the evidence. We develop evidence-based artifacts and so on. But these things keep on evolving. The knowledge keeps on changing. There's new technologies that are appearing and so on. And so it forms this sort of cycle, this continuous quality improvement cycle. And generally, we compile the evidence, we look at the literature, the data, then we start structuring it, L1, L2, L3, we start building these knowledge artifacts, ECQMs or CDS knowledge artifacts, for instance. And then we want to make this actionable. We don't want these to just sit in some kind of drive, and we want to be able to operate on this knowledge. And so we need to integrate it into the point of care. And then after that, we want to make sure does it impact anything? Does it really work? So we have to start measuring and seeing how this whole thing actually impacts what we're intending it to impact. And then if we realize it doesn't, then we got to sort of rethink where we are and then do further searches and so on, and then recreate new artifacts that ideally will be more targeted. So before I start on the demo, I wanted to just give, oh, I'm sorry, let me go back to the previous slide. So our focus here is going to be on how do we take these knowledge artifacts that have been created and how do we implement them into a clinical workflow. So I wanted to show you this. But before we do this, let me just give just a really high-level overview of some of the standards for those of you who may not be so familiar with them. So one of the main standards that we use is FHIR. FHIR we use to represent clinical information, for example, patients' conditions, medication requests, so for example, prescriptions, laboratory results, and so on. And they're a structured way of representing that information. It's encoded ideally, so it's semantically well-defined. And so FHIR is very important for this because it starts providing a standard way to exchange this information. But FHIR is not just about the data. FHIR is also about the operations you can perform on this data. In particular, the ability to retrieve the data, to persist the data, to modify the data. And so FHIR is an API. And so we have to remember that FHIR is more than just the representation of the content, but it's also how you get to the content and how you can update it in the EHR. So the second standard I just wanted to mention is Smart on FHIR. So EHRs come with functionality that's available to end users, but sometimes we want to extend that functionality. We want to be able to do things that maybe the EHR cannot do or tailor it for our organization and so on. So Smart on FHIR allows you to plug in an application into an EHR to specifications that allows you to do this, and you'll see it in the demonstration. And this is how we can actually plug in, ideally, functionality that's not already provided by the EHR into the EHR, or ways to make functionality more accessible, more friendly to a clinician. The third standard is a CDShooks standard. So let's say you have a clinical workflow and you want to invoke some CDS operation, some clinical decision support operation. You want to be able to do it in the right points in the workflow. And so the CDShooks specification allows you to hook up in specific areas of the workflow where this is most relevant. So for example, if you want to review a medication that's being prescribed by a clinician and check for drug-drug interactions and so on, you might want to do that at the point you prescribe because that's the right point in the workflow, and so on. So you might want to display alerts to a clinician when they open the patient record. So the CDShooks specification allows you to define these hooks, these points in the workflow, where you trigger a CDS call for some specific knowledge modules that you're trying to execute at that point, and also return the results, which can then be integrated back into the application that made the call. And these results are called cards, and the cards typically align with some area of the interface and populate that part of the interface. So here's a diagram which comes straight from the CDShooks specification site. You're about to prescribe, let's say, Toprol. You invoke a CDS service at the time you make the prescription, and then you get some cards that come back and they get displayed, rendered to the clinician at the right point in the workflow, at the right place in the application. So here is a close-up. So this is a bit technical, but I'll distill it. So you specify your hook. This is when you invoke your clinical decision support service. So here it's on patient view. So when you open the patient record, for example, you have an ID which tells you, well, what exactly do you want to invoke? It tells you the knowledge module and the artifact that you're interested, that you want to invoke here. And then here I have some prefetches. And what the prefetches are the data requirements that you have to provide me, ideally, in order for me to execute this clinical decision support logic. So here, I'd like to have all the patient's prescriptions. I'd like to have the latest blood pressure panel observation, which is represented by a loin code. I want to have the patient encounters, although in this case, we don't really use it, but it's in there. We'd like to have the patient. Obviously, we want not just a patient ID, but all information about the patient. In our case, we care about the birth date. And we want to know the active conditions, because our logic is going to depend upon what the patient has in order to render the recommendation. The clinical quality language is a very, well, it's a human-friendly expression language, so you can express typically the conditional aspect of a rule, for example, and it's an HL7 standard, and its goal is really to simplify the way that expression logic is written. We don't want expression logic to look like Java, or which is fairly inaccessible. So the language makes it friendly. Here you can see, for example, I can write expressions like my numerator has diastolic pressure less than 90 and has systolic blood pressure less than 140. So this is much more human readable, and we want to be able to at least expose something like this to an author of a knowledge artifact, so they don't have to go into much more sort of technically driven specifications. So you can see here there are different definitions. We define a numerator, we define pregnancy or renal diagnosis exclusions, and so on, and this is a bit more human-friendly. Okay, and then we'll start with the demo. Now, something that I wanted to mention quickly about CQL. So people often wonder, well, what exactly is CQL and how do we use it? Well, so this demonstration that you'll see is powered off CQL natively. So in other words, we don't translate CQL into some other language. We run it natively in a CQL engine, and it drives the entire logic for this demo. So before we go into the demo, this demo is based on JNC8, which is Guidelines for the Management of Hypertension in Adults, and also CMS 165 V8, which is a percentage of patients 18 to 85 years of age who had the diagnosis of hypertension overlapping the measurement period and whose most recent blood pressure was adequately controlled, less than 140/90 for that population. And so what we want to show is we developed a simple CDS application to illustrate this, to show, well, how could we implement this in the field so that organizations are potentially more compliant with the measure. And so this is a CDS logic that we've implemented. If a patient is under 60 years of age, has CKD, or the patient has CKD, or the patient has diabetes mellitus, we recommend that the blood pressure threshold not exceed 140/90. And otherwise, it's 150/90. It's a typo here. If they're 60 years old and they don't have diabetes mellitus or CKD. So it's simplified logic, but it's to illustrate the process. And then if the patient's last blood pressure exceeds that threshold, so we want to notify the clinician, and in particular, but we just don't want just notify, we want to make this actionable. So if the patient blood pressure is above recommended threshold and they are on medications, then we at least want the clinician to review the patient's medication, make sure the patient is taking the medications and so on. And if the patient is not on blood pressure medications, we'd like to recommend perhaps that they should be. So this is the interface that we have, the little, the top message box shows in red if the blood pressure is above threshold or not. And you can see that it's linked to this thing that says card 0. This is a response from CDShooks. So CDShooks gives cards as responses, and we tie them to different parts of the user interface. So the blood pressure goal, that comes back as a recommendation in card 1 of the CDShooks call. The last blood pressure itself is card 2. The current medications, the current prescriptions, blood pressure medication prescriptions for the patient is represented by card 3, and it's shown in the interface over there. And then we also have recommendations. So we allow the clinician to take actions, not just have an alert. And we bring all that information to the clinician. So in this one dashboard, the clinician has the information, the patient's relevant data, and also the ability to act. Okay, so now I'll go with the demo. If I can find my mouse. Okay, so this is a demonstration. You select a patient, and then, so here I have a patient. Let's say I load the patient, and so this is a patient who's healthy. Their blood pressure is 76, is 118/76. It's a 53-year-old male. They have no medications, blood pressure medications. They don't seem to have any conditions on their problem list. And so when I'm demonstrating, or at least when I'm displaying the information for this patient, it says the patient's blood pressure is within the recommended range. It's green. You can see the goal, 140/90, so that you don't want to exceed this threshold. And then the last blood pressure is 118/76. It's green. It means everything's good. We found no prescriptions, blood pressure medications. If you remember, this service took all the patient's active prescriptions, and here we filter them and display only the active medications. This is done by running the CQL natively in the CDS side and filtering the medications based on the CQL expression. Now, if I change the patient and I pick another patient with another profile, this is another patient. This patient has a blood pressure of 110/75. The goal is also 140/90. It's a female patient, 45 years old. And if I look at, this is the observation in the patient record. Medication order, she's actually on blood pressure medications. Condition, she's been diagnosed with hypertension. But there's no recommendation for this patient because her blood pressure is normal. There's nothing really that needs to be done. The information is all presented in front of the clinician. So now if I change the patient and I pick another one. So this one is a patient, so it'll take a few seconds. So this one is a patient, 57-year-old female, on blood pressure medication. Her blood pressure is above the recommended threshold, 151/92. And you can see now we're making a recommendation. Because the patient is on medications, our recommendation right now is just a button. You would implement it as you would feel would be the right way to implement it in the EHR, but it's really to recommend a reassessment of the patient's medication, make sure that the patient is compliant, maybe consider a different medication or an adjustment of the dose. It's a fairly complex process, so we didn't represent it here. And if you look at the conditions, the patient has hypertension, and then the medication is that specific medication. Now, if I pick another patient, so here is another patient, and I'm going to go back to the demonstration here. So this patient has blood pressure that exceeds recommended threshold, is actually on a medication, but this is Nexium, so it's not a blood pressure medication. So when you go to the demo here, you can see that there's no blood pressure medication, and therefore the recommendation has changed. Now we're recommending that the patient take take some medications, and so some medications are presented here. Which medication you present depends upon your organization and so on, but these are some examples. So this is just a description of how you can actually integrate CDS at the point of care. This is integrated on the patient view. I open the patient record, I see this information. And one more thing we wanted to show you is I'm going to click on this link here that says BPM demo. What I showed you here, the engine that runs this is a CQL engine. So it's a native CQL engine working on the CQL expressions that have been written for this knowledge artifact. And then here, this is actually a different engine. You notice no change. It's identical. But actually, this is calling a different knowledge module that's running an engine that's based on DMN, which is a decision modeling notation, and it's based on a different standard, an OMG standard, and it's completely transparent to the end user. I'm just calling a different knowledge module, but it's representing the same information, same visual display, because the CDShooks response that's coming back from the execution of the logic is identical between the two. So the execution of the logic is a different engine. What coming back is the same. The interface knows how to display the results of the CDShooks call, and so everything looks identical. This is a quick view of what's happening here. So we have that whole application that you saw in the center screen. That's a Smart on Fire application. It's integrated into the EHR. It's coded by us. It makes a CDS call, represents the information. But this is the power of Smart on Fire, is that you can embed these applications into your EHR, and it fits right there within the EHR, provided the EHR is Smart enabled. Then we pass in the CDShooks request to the EHR. In this case, it's a mock EHR because we couldn't show Epic here. And then the EHR is responsible for executing the prefetches, so it makes all the calls to the Fire server. It passes it to an open CDS engine. This is a framework for running clinical decision support applications. And then the open CDS engine passes all the information to the knowledge module, executes it, gets the cards back, and returns it to the Smart app embedded in the EHR. So these are all the standards: Fire coming in, CQL executed at the knowledge module, CDShooks to make the invocation of the CDS call, and the Smart on Fire application, or the Smart specification to embed the application in the EHR. And so this is just a description of the CDShook service. You can discover them. You can see where they are and what prefetches, for example, they take. There are two here for the two different engines. And this is a CQL, or a sample of the CQL that we used. And that's it. So, any questions? Thank you.
You said that you're executing CQL natively. Is there any translation or anything that happens within the execution engine to be able to retrieve the data you're looking for?
So what we do is we take, so actually the demo is a little more complicated, but we have different variants of this demo. But the prefetches, so the Fire data is passed into a CQL engine along with the expressions that you're trying to evaluate, and then it returns the result. So generally it's Boolean, yes, true, the patient has high blood pressure or not. But there's no translation. This is completely automated. Now, in this demo that you saw, actually what we do is we take the Fire messages coming in, we translate them into a logical model. This is done on the fly. And then our knowledge artifact was actually not written against Fire. It was written against a logical model that is version independent of Fire. So we could run this on DSU2, STU3, R4, it would still work. These are the different versions of Fire. But yeah, there's very little you need to do. You give the Fire data, you have the CQL expression, you run the engine on it, it gives you the condition part of the rule, and then the consequent is a recommendation that you're providing.
Okay, thank you.
Excuse me, I have a quick question, just adding on that. So you were using the CQL logic plus Fire data model, which is different than what we're currently using. What we're currently using is CQL plus QDM. So the only one new thing is Fire data model.
Yeah, that's right. So I'm using a logical model, which is supposed to be the next generation or an evolution beyond Fire of QDM. We're going to propose this at HL7 in January for comment ballot. But technically, I could have taken QDM and made that the logical model, and I could have run all my logic, translating the Fire messages, operating the knowledge artifact on QDM, and returning the results. Now, we didn't do this, but we could easily do that.
Oh, okay, thank you.
You're welcome. Thank you.
All right, good afternoon, everybody. I'm Michael Barr, the Executive Vice President for Quality Measurement and Research at NCQA. It's my privilege to moderate the pop-up panels. So can I have my pop-up panelists pop up onto stage? So we have three speakers. Dr. Bryn Rhodes from Dynamic Content, who's going to talk about accelerating evidence into practice and build on a little bit of what Claude just talked about. Dr. Viet Nguyen from Stratometrics is going to talk about Davinci data exchange for quality measurement and how to facilitate that. And Paul Cotton, who's the Director of Federal Affairs at NCQA, is going to relate some of the lessons learned and conversations at the state quality reporting, electronic measure quality reporting efforts. And I know that Viet was in a couple of different tracks, pulled some tracks together. Bryn was in track 5, and Paul was in track 4. But we're going to have them speak each for about 10 minutes, answer some questions, and then turn it to the, and then you'll have a chance to ask questions. Hopefully they'll be able to answer them. And then if we have enough time, I'll ask you for contributions in terms of what you heard that was exciting during the meeting. So let me turn it first over to Bryn.
So my name is Bryn Rhodes. I've been working for the past probably 5 or 6 years on knowledge representation standards and trying to get a translation path to accelerate evidence into practice. I know many of you have probably been working on that same problem for much, much longer. So I appreciate that. And we have been lately working specifically with the opioid prescribing guideline. And looking at how we can deliver the highest value computable content for that guideline and how that relates to quality measurement, and specifically some of the opioid guidelines that are, or opioid quality measures, are actually able to share content between the opioids, like safe use of opioids, and the quality or the decision support content that we've put together. So we've built out libraries of shareable content, not only between decision support, but between decision support and quality measurement. So we think that's a step in the right direction as far as enabling guideline developers to produce more computable content as part of the process, and share that across the continuum and across the stakeholders. So that's what I've been working on, and that's me. Okay.
How about some of the content in track 5 in terms of the, I know
Oh,
you
right.
talked about sort of what's critical, what's doable. There was a nice grid you guys produced. Do you want to relate any of that to the team?
Yeah, so as Claude's presentation showed, we have, what we use often is a framework of levels of knowledge. So as we structure from narrative going to semi-structured to structured, and then all the way to executable content. We've focused, in terms of sharing this content, we've focused on the level 3, actual computable content. If you think about the way quality measures are currently distributed with ECQMs, that's a great example of an L3 document, because you have a machine-readable format that isn't natively executable. You have to have an engine that can actually run that, and you can either translate that target to something like SQL, or you can build a native engine that can run it directly. A lot of times what happens now is, even though that's a computable format, there's still a lot of just manual translation of that effort. And so we're trying to improve the shareability, and that's why we've targeted that level 3, so that your implementation choice can be determined by your particular system's requirements. So you can get from L3 to L4 more quickly without having to do a lot of manual development. So.
Any questions for Bryn? What's the next challenge for, what would you like to see next coming out of this conference with respect to the conversations we had in track 5?
So one of the things we talked about was actually getting a specific pilot together, and bringing that back, as a group and as a community of stakeholders, working on different aspects of that pilot over the next year, and then bringing the results of that back to try to help explore some of these areas and push the envelope further. I don't know whether it's opioid management or blood pressure management. Pick a new workflow. But the idea was to get participants involved in expressing the content and piloting that content in specific locations to help just kind of learn more about how this can realistically be done and how it can actually turn around improvements in the measures and how you measure. So,
Thanks, Bryn. Now I have a microphone, so I don't have to shout. Yeah, I think what was exciting, because I sat in track 5, was the energy around what you just described, sort of the practicality of the clinical decision support and how it could guide care. I think Claude's demo is a good way of showing sort of how it could work, but then the idea was, how does that really drive care, close the knowledge gaps at the point of care, and really evidence and implementation of evidence into practice in a lot quicker way. So I was really excited about that. So hopefully next year, the team will come back and show us some real-world implementations and pilots. Any other questions for Bryn? Comments? Thoughts? All right, let's turn it over to Viet. Thank you very much, Bryn.
thank you.
Good afternoon. I'm Viet Nguyen. I'm a clinical informaticist, and I'm the technical director for the HL7 Davinci project. And really briefly, for those not familiar with the Davinci project, it's a payer, provider, vendor collaborative formed under HL7 to address value-based care and problem space around the payer-provider interactions and data exchange and sharing. And so we have been working fairly furiously for the last year and a half and have a lot more work to do, but we have 3 main work streams, one around exchanging clinical information between payers and providers, not just from providers to payers, which everyone's familiar with, but also from payer information back to providers. We have a work stream around trying to improve the prior authorization process and providing more information that's computable in that process, and also helping reduce provider burden. And for this community, we have a work stream around quality measures. So we're the sponsor of the Data Exchange for Quality Measures Implementation Guide, which is one of 3 in a companion set of guides that includes the Measure Implementation Guide led by Bryn and others that help take how do you define a quality measure at the front end from the authors, also using CQL, so it's a computable and shareable artifact. And we also leverage the QI core profiles, which are FHIR profiles based on the US core, so we're using standardized profiles in FHIR. And then the DEQM, the Data Exchange for Quality Measures, represents how do you share that information, how do you request it from a data producer, such as a hospital system, a lab, a diagnostic center, and deliver it to a consumer, which may be a provider, a payer, a registry, others, and that it's also going to include kind of the broad concept of gaps in care. We were very fortunate. We have a great faculty, and we joined also with the methodology group, the measures terminology group. And so just to recap what we did, on the first day, the first afternoon, we had a FHIR tutorial, which turned out to really exemplify a saying we say in med school. It's like taking a sip of water from a fire hydrant. So we covered a lot. And what we learned from the end of the day was maybe we covered too much, too fast. And we asked folks what their level of comfort was from 1 to 5 around FHIR, 1 being very little to 5 having written applications. And I think in the group about 60 or so, the average might have been 1.1. So the second morning, we reevaluated, and we actually split the group up, and we did an additional FHIR, more basic FHIR, where we took the colon cancer use case, the colon cancer measure, and went from what do we think the data would be, all the way to how do we represent that in FHIR, all the way to the example of FHIR instances that we had in our sandbox. And I think that really helped folks connect the dots between the concepts that they learned on Monday around FHIR to actual applications, and we showed them what we did in Davinci around our reference implementations. And then we had another group led by Yan Hu, who also showed how we use Atom and did authoring of CQL and of a measure. And so our goals were really to try to help folks appreciate this transition we're going through from this QDM space all the way into FHIR and CQL space. So I think that was really successful. I want to thank the faculty who participated in that. Some of the takeaways that we had, folks really appreciated the tutorials. I think they wanted more tutorials and more diverse tutorials in both in depth of work, all the way from deep into maybe writing code, all the way to higher up more for executives, and more use of the tools and more hands-on work, which is always great. And so one recommendation I would give is if folks are interested in more education, HL7 provides a lot of education, both at webinars in between the working group meetings as well as during our working group meetings. The next one's in September in Atlanta. And we also wanted to do more work around Atom and CQL and look at other measures that are being worked on by the folks at CMS, like the ECQMs and the conversion they're doing there. And just more examples. I think another learning that we want to share with the group is that we have to recognize there's some time lag between the relationship between the different implementation guides in FHIR. So for those who are unfamiliar, we have FHIR R4 version that was published in December, and that's the first version that has normative components, meaning anything that's produced going forward should not have breaking changes, or if they do, they have to have really good reasons, which should give the community some reassurance that there's some stability in FHIR. So things that we commonly use like patient, practitioner, organization are really solid. They've been tested by the community, and we're going to advance other resources over time and get them to that normative stage. And then the US core profiles that are built on R4 have been balloted and are going through reconciliation and publishing now. And then our QI cores, which we use in the quality measures, are dependent on US core. And so those are getting balloted in September. So those dependencies on the various stages of FHIR and the standard development is part of the reason why you're not seeing requirements for FHIR in measures today, because we need to get to the point where we have some stability for the vendors and others who have to work with FHIR. Let's see what else here we have. We talked about gaps in care. I think there's a general agreement that gaps in care are a kind of quality measure in that they have to be defined, they have to be shared, they have to be reported upon and measured. And so Davinci will be initiating a use case through HL7 probably in the next couple of months to work on gaps in care and how that relationship between payers and providers and that information is shared. So we encourage folks to go to confluence.hl7.org, find the Davinci webpage, and sign up for that listserv if you're interested in working on that with us. We also want folks to understand we're in this period of transition, and that we have a vanguard group led by CMS and NCQA that is really trying to solidify these best practices in quality measure authoring, reporting, exchange, and that we need your participation. So we encourage you to join HL7, participate in Davinci use cases, join the NCQA's new digital measurement community, and participate and provide your expertise, because we are standards developers. We're not necessarily the business owners or the subject matter experts, so we're here to work and support you. And I think the other recommendation is start taking back what you've learned here about FHIR, talk to your organizations, and help them prepare themselves for this future in health IT.
Wonderful. Thank you very much. Any questions for Viet? You guys want to get out of here, I see. Oh, great. Thank you so much. Wonderful. And last but not least, Paul Cotton, Director of Federal Affairs, NCQA. And before he starts, we'll have a little time, so if anybody wants to stand up and state your observation or lessons learned during the last 2.5 days, I'll give you that opportunity. Don't be shy. But Paul, let's hear from you.
Thank you for bearing with, and thank you all for being here and for sticking through to the end. This has been an incredible 3 days. Andy Reynolds, when he kicked this off on Tuesday, said this was a working meeting, and that is what we did in all the tracks, and especially in track 4. We just got in there, rolled up our sleeves, and got to business. The reason we did this track was at NCQA we realized that several states were working in isolation, trying to advance electronic clinical quality reporting, and there wasn't a lot of interaction between them. They were all sort of pioneering on their own. So what we wanted to do was bring people from different states, all of who are at different stages along this journey, get them in the same room and try to do a couple things. First, identify what are the key challenges that they're facing. Even though they're all at different places on the journey, they all have very similar challenges. And so we spent the first afternoon just trying to define what are the key challenges that we need to address so that we can move forward. The second day, we broke out into working groups, and we had 5 different working groups for 5 different challenges that 5 different challenges you can see up there, and each one at each table had very in-depth discussions, both morning and afternoon. How can we address these challenges? Can we first better define the specifics? We got really down into the weeds. What are the specific problems and issues that are inside each of these challenges? And then on the third day this morning, we all got back together, and each of the track leads presented on what they found out in their little working groups at the tables. We brought them all back together. We had a very robust discussion among all the participants about what are the common themes here and what can we do to move forward. There is a great deal of overlap between all of these, and as with everything else at this conference, everything is interrelated. But we were able to identify some very good themes. I was incredibly grateful that our track had 4 great faculty leads from 4 states. We had Linda Shaughnessy from here in Massachusetts, Jim Kirkwood from New York, Kate Lomberg from Oregon, and Kelly Crosby from North Carolina. Each of these states is at a different place on their journey, and they really helped us to understand how the similarities across the states, despite the different places on the journey. And the 5 challenges you can see up here were first, alignment of measures and reporting parameters, expectations versus the reality of EHRs, because there is a great deal of difference there. Provider versus plan level measures and a lot of complexities inside of that. Varying levels of readiness across states and providers and other stakeholders. And then finally, the accuracy of the data that's being used for measurement, and that was the work group that I led. But we were able to find some commonalities across each of these things, and we this morning came up with some common themes, takeaway messages that we need to work on to move forward, and you can, that's tricky. All right, the key takeaways. First of all, to move forward, we shouldn't try to do all the measures. We should narrow our scope on those that are most important to the Medicaid programs. Medicaid really wants this electronic reporting, but we need to focus on measures that are most important in Medicaid. Those are things especially like behavioral health. That's a big issue in Medicaid, and how behavioral health interacts with other chronic conditions, care coordination, things like that. So we want to focus as much as we can on the small set of measures at first that will be most meaningful in a Medicaid program. We need to communicate better to all the stakeholders what we're trying to do and our timeline for getting there, because people really don't know right now. Each state's on its own timeline, but we all agreed that we need to make sure all the different stakeholders know what we're trying to do and how we're trying to get there and across what time. That's very tricky. No, you're just messing with me now. We need to include all stakeholders from the start. Plans, providers, consumers, vendors, states, CMS, ONC, everybody who is going to be part of this process, they need to be a seat at the table so that they aren't coming in at the late, hey, you didn't include us, we have concerns here, you're moving forward in a way that's not good. We need to make sure that all the different stakeholders are there at the table. Especially, we need to build a very strong business case for why we want to do this. Folks in this room all clearly understand why we want to move to electronic reporting. Not all of our stakeholders understand that yet. So we need to demonstrate why, for each stakeholder, why this is going to be a better way to do quality measurement. We need to demonstrate successes. We thought we could start in some of the more advanced states. A couple of states are much farther along than the others. Can we do some work in those states to really demonstrate, hey, we can do this electronic reporting. We can demonstrate the benefits. We can show to the different stakeholders, this is how this has actually helped you on the ground in this state. In that case, each of the stakeholders in that state can communicate to their partners in other states. Like, for example, if a plan is in many states, the success in that first state, they can evangelize that success to other states where they function. And then we need to share the best practices that we learn from those states that are out front so we can help the other states know what are the best levers to use, what are the best incentives, what are the problems they're going to find along the way, and how to address them. And finally, we need to strengthen trust. There's been a lot of mistrust in interoperability, the data blogging, people not knowing what they can and can't do with HIPAA or using it as an excuse for not sharing. And so we want to make sure that we are building that trust so that people will share the data and move forward together. And that's what we did in our track. I'm incredibly grateful for the track faculty and all the participants. We had very robust conversations, and it was a very, very satisfying experience. So thank you, and happy to answer any questions.
Great, thanks, Paul. Any questions for Paul? Oh, we go right to applause. There you go. Any questions for Paul? Were there any like you listed some key takeaways and stuff. Was there anything surprising from the conversations that you didn't expect to come out of the discussions?
I thought that with different states being at very, very different places, there would be more differences, and there really weren't. When we agreed what the challenges were and what the takeaways were, we came to the consensus fairly quickly, and so it was surprising. There is a common set of challenges and a common set of ways to move forward, and it was really gratifying to see that we were able to identify those.
Great. Andy, you have a question.
Paul, what did your group have to say about the issue of burden or burden reduction?
That came up in almost every discussion. The whole point of this is to reduce the burden. One of the key points in making the business case is to demonstrate how this does reduce that burden. We believe we can reduce the burden, and that is one of the strongest arguments in the business case. And once we get the states that are farther along to demonstrate, hey, we have reduced burden, improved accuracy, and gotten the measures that matter, that's going to really help us move this forward.
Great, thanks. Any other questions, comments for Paul? If not, I'm going to ask if anybody has any observations. First of all, thank you again, Paul. Anybody have any observations or questions or just statements they want to make about the experience? If not, that's okay. I know it's been a long 2.5 days. Once, twice. Oh, okay. I know this person.
Hi, I'm Jenna Williams-Bader. I'm a Director of Performance Measurement at NCQA. I was in track 3, but we had a small work group that was continuing work from last year, thinking about measures for rheumatoid arthritis and specifically using disease activity assessments to assess outcomes. And one of the most important things for rheumatologists that our group identified to be able to track is medications, and in particular the dosage of medications and how those correlate to the disease activity of patients so they can actually prove the usefulness of these medications, because RA is a condition where you're really trying to treat it very aggressively at the beginning, but the medications can be really expensive. So there's a lot of plan involvement in the choosing the medications. And rheumatologists really want to be able to make the case that they are providing the best care possible to their patients. But I think a lot of us know that have been working in this space that trying to get medication data, useful medication data, out of records is challenging, particularly when you want to start drilling down to dose. And we all know that medication reconciliation can be really challenging as well. And for RA, there's also, you're not just looking at a lot of these medications are injections. So I don't know if anyone else has reflections or thoughts on medications in particular and how we can start getting to the really useful information that will help clinicians, ultimately help patients because they'll be getting better care. And because we did talk to a couple vendors and the fields are there. There are discrete fields that help you get to the data points that clinicians want, but it's a big mess. they're not necessarily filled out. A lot of the information's ending up in free text fields. So I just wonder if anyone has any brilliant ideas about that.
Somebody have an answer for her? A solution? I mean, it seems to me that the kind of issue, just in general, that you just raised is sort of what we're hoping that digital measurement community can help support that we're building. So a question like that, if we can't do, is there somebody, I see somebody, sorry? Oh, Bryn, you should have just chimed up. So let me just finish my thought and I'll turn to Bryn. But these are the kind of questions we want to have ongoing conversation about and discussion. So if we don't get an answer for you here from Bryn, I think, you know, the sharing information insights across sort of the community would be helpful. So Bryn, let me give you the microphone.
Sorry. So Via pointed out that there is a U.S. core profile, and so hopefully that will help to try to move in that direction for standardizing some of how that content works. In the opioid prescription management, what the University of Utah did was end up building a huge amount of code to parse free text SIGs, because the dosage information in that calculation is critical, right? And so they ended up doing an analysis of all of the prescriptions that they had in their system, and built up, you know, a Java parsing library to pull. The problem is, it only worked for the patterns. It only worked for about 80%. There were about 20% that you just, you know, who knows what that says? It says Tuesday. We don't know how to interpret that. And so, you know, 20% you couldn't get at all, and the 80% that they could get really were dependent on the patterns that the clinicians in their particular system used. And so we did take that and convert that library to CQL, and it is available in the opioid content. So if it's something that might help, you could take a look at it. That is a shareable library for parsing free text SIGs, but it comes with those caveats that, you know, obviously it's subject to the patterns of the users that are writing the prescriptions, and the systems and the policies in place for whether they're required to write, you know, use the signature or use the quantity. So yeah, it's a super challenging problem.
And I wanted to offer a model that actually came out. So this is my third DQS. I was here at the first one.
You're a long-term alumnus.
And the group in the first DQS, we created actually a visual model and a mental model. And I'm a terminologist by trade, so we talk about this notion of impedance mismatch, and the impedance is resistance, and it's these interfaces where there is an opportunity for improvement and loss of data, and it's almost always a loss. And so we looked at, if you look at the first interface is the patient to the provider. So that's a human-to-human interface, and so we hope that clinicians are asking the right questions and gathering the right information. The second interface is the clinician to their EHR. So the EHR or their system needs to be able to capture the data in a way that maintains that fidelity and quality of the data. It gets stored in the EHR's data model, and we haven't gotten to interoperability yet. So that they have to be able to store that data, and then, assuming those parts are good, we have FHIR, and so there's a certain mapping that has to be done between the EHR to FHIR, and then you get to FHIR and you can share the data with profiles and such. And so since this is a digital quality summit, I think we have to all recognize that data quality is just like a chain. It's as good as its weakest link. So I think we have to emphasize that we all have a responsibility as clinicians to gather the right data, as vendors who build systems to make it possible for clinicians to gather data, and then that allows us to really effectively share the data via interoperability standards. Just want to make that comment. And medications is a good example of how that can be very challenging.
Great, thank you. Other comments, questions, follow-ons? No? Well, what one? Okay, somebody coming up. Great.
Just kind of like a Dave Grinberg from Imprado. I too am a long-term alum, you know, all few years, but I've actually been at this a lot longer between interoperability and data information governance. And I would like to say to all the folks that are here that it feels like we've been on this road a really long time, and it's very easy to get dispirited because we seem to be facing an uphill challenge. But I'll tell you that it is this event every year that I attend that makes me feel better about the world and makes me feel like we're headed someplace, because there seems to be consensus among this group of like-minded people that see it as a challenge that we can all approach and solve. And so I would like to take the opportunity to thank NCQA and HL7 for giving me my inspiration, which re-energizes me and lets me keep going. So.
On behalf of, thank you. HL7. Well, let's just end right there. That's perfect, right? So any other comments, questions, thoughts before we close? From my panelists, the pop-up panelists, you popped up really well. Good job. Another round of applause for these guys. And let me thank all of you. A round of applause for all the attendees who stuck it out to the end of the conference. Please, thank you. I also want to thank our sponsors, the track leads and faculty, the speakers, the staff, obviously HL7. And also, let's give a round of applause to the hotel and AV staff for their support and service. They did a great job. And we really do hope to see you next year at the Digital Quality Summit 2020. We'll be posting dates soon, so stay tuned. We invite you to join the digital measurement community. You saw the URL, ncqa.org/DMC. And have a safe rest of your summer and travels back to wherever you go. Thank you again for joining us. Take care.